Today we're going to be doing the NG tube insertion. This skill is a non-sterile skill. You'll need to first check your Cardex, make sure you have an order to do this. It is an invasive procedure, so you want to make sure that you check that Cardex against your chart and the original order. You also want to ask permission from the patient that it's okay to do this. The next thing you need to do after you've checked your order is assemble all your equipment. The things that you will need is definitely you're going to need an NG tube, and the order will determine what size NG tube that you will use. It won't be written out. The physician won't tell you what size to use, but based on what the order is for, you can determine the size that you will need. A small tube is considered a 5 to 12 French. All NG tubes are measured in the French system, so the larger the number, the larger the tube. So a 5 to 12 is considered a small bore tube, and most of the time those are used for feeding, bolus feedings and things like that. They're not usually used for suction, and you may see them called Dopoffs or flexi-flow tubes. A larger tube or a large bore tube is something greater than 14 French. Those are usually used for decompression of the stomach and suction and things like that. They can also be used for feeding and medication use. It just depends on what the physician orders them for. So, let's say the physician has ordered this NG tube to low wall suction. I will know that I'm using this tube for suction, so I'm going to pick a larger bore tube. So, this right here is a Salem Sump, is what I'm going to be using today. It's just the brand name of these, and they look a little bit like this. So they may have some different types, but this is the one I'm going to use today. These are new when you open them up, so they're very stiff. You may have to curl them around your fingertips a little bit, about 12 to 16 inches. Curl them around your fingers. And this will soften this tube and allow it to be a little bit more flexible when you open it. So once I've assembled my equipment, I'm ready to go in my patient's room. So of course I'm going to knock. I'm going to introduce myself and greet my patient. I'm going to check their name tag, make sure I have the right patient for the right procedure. Next, I'm going to get them in the appropriate position for NG tube insertion. And this is going to be the high Fowler's position. Just this here. You also want to, after you have introduced yourself and you've made sure that you've got the right patient for the right procedure, you also want to explain to the patient about this procedure. It is going to be very uncomfortable. A lot of patients will gag and cough when this is going on. And you want to just encourage them, explain why this procedure is needed. Knowledge is always, it helps to combat anxiety during a procedure. So make sure your patient is well aware of what's going on. So next I'm going to assess my patient. It's very important before you put this tube down, you know the best placement for it. So I'm going to ask Ms. Long if she has ever had any type of nasal trauma, if she's ever had any type of surgery. I'm also going to test for patency of the nares, so I'm going to have her occlude one side of her nose and have her breathe in deeply. And then I'm going to have her do the other side. And I'm going to determine which passage the air flows freely through. And then I'll go from there, decide which side to put it in. So with Miss Long, it's going to be the left side. So next I'm going to go ahead and get my gloves on. You just need clean gloves for this procedure. This is not a sterile procedure. And I've already taken this tube because it is new and I've curled it around my fingertips 12 to 16 inches to make sure that it's flexible. And next I'm going to go ahead and measure before I lubricate this tube. And how you measure, you want to remember the acronym NEX. That means nose, ear, and xiphoid process. So I'm going to take this tube from the tip of the nose to the ear, and I'm going to mark it with my fingers, and I'm going to hold on to that spot. and then from the ear down to the xiphoid process. And then once I get that measurement, I'm going to mark this with tape. This is a way to determine how far down you need to go to reach the stomach. You may have to adjust once you get there based on when you check for placement. So now that I've got this marked how far I want to go, I'm going to go ahead and lubricate it. You want to use a water-soluble lubricant. Do not ever use an oil-based lubricant like a petroleum jelly. This procedure has the possibility of, instead of going down the esophagus into the stomach, you could possibly go down the trachea into the bronchial trees. When this occurs, the patient will cough forcefully. They may have some respiratory distress, maybe a little stridor when this happens. So you want to make sure, if that happens, if they start coughing and gagging, you want to pull it back, and then you can advance it again. But if they start coughing, that's usually a sign that it's in the lungs instead of where it needs to be. You can also, when you're passing this tube down, we'll get to a point where you'll look in the back of the mouth, and a lot of times you can see sometimes it will curl up in the back of the mouth. That's a possibility as well. So now that I've determined how far that I want to go, I'm going to lubricate this about 3 to 4 inches. So I've got it ready. I've also got in place my equipment, my stethoscope, because I'm going to have to check for placement. You're going to need a syringe, preferably a Toomey syringe. That's just the proper name for this. You can also use a bulb syringe, but a Toomey works best. You're going to need a cup of water, just some basic tap water for your patient. You're going to have them help with this procedure. They're going to have to take sips of water and swallow. And when they swallow, you can advance the tube, and it makes it go down a lot easier if they can assist you. You're also going to need some tape to secure the tube once it is in place. You may also use, your facility may have nose guards and things like that, but it depends on your facility, but tape will do the job. And you're also going to need a safety pin and a rubber band to secure the tube, and I'll show you that in a few minutes. And the last thing you'll need is a towel. Sometimes patients get sick during this procedure, and this is just to protect your patient's linens and their gown. So I marked my tube, I have lubricated it, I have assessed my patient. One more thing you might want to assess for is bowel sounds. A lot of times you'll be putting this tube down because that patient has a hypoactive bowel sounds or something of that nature. So I always like to, as part of my assessment, assess the bowel sounds as well. So for this, of course, you want to place your stethoscope right against the skin. You do not want to place it over the gown or linens, and I'm going to listen in all 4 quadrants. So now I'm ready to put this tube down. I'm going to tell Miss Long during the first part of this procedure that I want her to tuck her chin, I want her to raise her chin up in the air and hyperextend her neck, or to tilt her neck backwards. And this allows me to see up in the air and to be able to pass this tube safely. And then when I get to a point, I'm going to ask her to open her mouth, and you should be able to see this tube in the back of the throat. And at that point, I'm going to have her tuck her chin to her chest, and that's when she's going to take those sips of water. And you need to explain this to your patient before you get started, that they're going to have to assist with this. So we'll go ahead and start. Okay, Miss Long, I want you to raise your chin up in the air and tilt that neck back just as much as you can. And then I'm going to go ahead and insert my tube. It's going to kind of curve downward, and what you're going to do is pass this tube along the floor of the nasal passage. You're going to start to meet some resistance in the back of the nair, and what you do is curve that tube towards the other nair, and it should pass a little bit further at that point, and then you'll start to see that tube in the back of the throat. So here we go. Just breathe for me, Miss Long. So I'm meeting a little bit resistance. I'm going to curve that tube a little bit. There we go. Now at this point, I'm in the back of the throat. Okay, Miss Long, I'm going to have you tuck your chin to your chest, and I'm going to have you take little sips of water. Now you also want to tell your patient if it gets to be too much, if they need me to stop, take a break, establish a communication method. You may have a piece of paper and a pen, or what I like to do is have them raise their right hand. Just raise your right hand if you need me to stop, and I'll stop for a minute and give you a break. So at this point, she's tucking her chin, she's taking sips of water. I'm going to say swallow, and when she swallows, I'm going to advance the tube. Okay, Miss Long, swallow, swallow. And you're going to do this to the point where you get to this tape area, which told you how far to go down. And once you reach that area, which is a little bit difficult on these mannequins, they don't advance very far, you're going to stop. And what I like to do before I secure it is check my placement. Now you may have a patient that moves around a lot, or that is at risk for pulling this out, and you may need to secure it at this point. But Miss Long is very compliant, and she's not going to pull it out. So what I'm going to do now is check placement. The first thing that I want to do is draw up about 20 cc's of air. I'm going to clamp my tube by bending it in half, and I'm going to connect this syringe with the air. And now I'm going to place my stethoscope over the side of the stomach. And the stomach is to the left and above the umbilicus. And then I'm going to push this air in very quickly. And what you should hear when you do that is a swishing sound, or some people call it a bubbling or a gurgling, but it will be pronounced. You will definitely know that you hear it when you push it in. Now next I'm going to pull back, and this is called aspiration. What I'm looking for is stomach contents. Usually stomach contents are like a greenish color, and I will know I'm in the stomach. You may go down into the small intestines, and those are more of a brownish color. So you're just going to look and make sure you're getting those contents pulled back into this syringe. If you're not, that could be an indication that you're in the lungs, so you don't want to put anything down this tube. So then I'm going to reconnect it. Another tip that's not in your book to determine if you're in the lungs, if you're not getting any of those contents back, you don't see anything when you aspirate, you can take and disconnect this tube so it's not clamped, and then I'm going to take a cup of water and put the tip of it down in that cup of water. If there's bubbles coming around the tube, coming up in the water, then you know you're in the lungs, because that's air from the lungs coming out. Now, I have heard the swoosh of the air, so I know I'm in the stomach. I've also checked for stomach contents. You may also be asked to check those contents with litmus paper to determine the pH. That's just a facility protocol. Every facility is different. And the litmus paper will tell you it's a certain pH, and this is indicative of stomach contents. So it just determines what your facility policy is. So now I'm going to go ahead and tape this and secure this NG tube. So what I usually like to do, which tape just loves to stick to gloves, is take a strip of tape about a couple inches long, 2 to 3 inches long, and I like to split it halfway so it looks like a piece of tape kind of with 2 legs on the end. Take the solid piece and put it across the bridge of the nose. And then I'm going to take the split piece and wrap it around my tube. Now, like I said, your facility may have nose guards. Those are wonderful. But if not, tape works just as well. And then next, to secure it, to keep the patient from inadvertently pulling it out, you want to take a rubber band, and you're going to wrap it around your tube, kind of pull it through like so, and take your safety pin, hang it on your safety pin, and then pin it to their gown. You want to leave a little bit of slack, that way the patient can turn their head freely, they can move around freely, but not so little slack that they can pull the tube out. So what this does is secure that. Next, I'm going to follow my physician's orders. The physician may, if they wanted it attached to suction, you need to have suction set up and go ahead and attach that. If they wanted maybe to check placement with an x-ray and then start feedings, you want to make sure you carry out those correctly. So next I'm going to get Miss Long in a comfortable position. I'm going to take off my gloves, get her back in a comfortable position, clean up all my supplies, and then I'm going to wash my hands and document the procedure. I'll tell you a bit more about documentation when you come for the lab that day.